Since addiction is being recognized as a disease and no other disease that I know of is treated as a criminal offense, do you guys see laws changing to protect people who suffer from addiction rather than being punished for it?
I was mainly talking about the laws as they are right now. I certainly am not a legislator. We may have a legislator in the audience, but I can't necessarily forecast where laws are going in the future. I do think, as Robert described to me before, and as we've heard from all the folks on this panel, what I do see is an increase in the understanding of addiction. Now, whether or not that manifests fully in our criminal code, I can't speak to that. And the laws as they are right now, the state of the laws as they are right now is the state of the laws. But there are people like Robert that I think are working in a progressive manner to bring about that understanding, perhaps at the governmental level, that could potentially affect some of those changes. Robert, do you want to add to that answer?
Hello, thank you all for attending, even the people in the audiences. I guess my question is primarily for Dr. Scott Kirkley, if that's how you pronounce it. Hope I didn't butcher it too bad. I really appreciate you spending your education and your life, trying to help others with medically assisted treatment, which I'm a fan of. I mean, I think that's the only approach to get people off of it. What is your take on the 3 to 5 day detox and then out the door? Do you ever see, let me follow up with that, do you ever see a 3 to 5 day treatment followed up by a shot of Vivitrol? Because a lot of times they're kicked back out on the street. We were talking earlier up there about cigarettes and coffee. If you take someone off of cigarettes for 3 to 5 days, or off of coffee or nicotine or caffeine for 3 to 5 days, first thing they're going to do, if they're not completely committed to getting off of that, if they're going to go out and have a cigarette, probably 2, or they're going to go out and have a cup of coffee, maybe chase it with a Mountain Dew. And the same thing is happening on the 3 to 5 day detox. All the heroin, the opiates are out of the system. That's about how long it takes to clean up. Am I about right? Is it 3 to 5 days and most of the opiates are out of your system?
The like measurable amount in the system,
right.
Yes, but
so,
withdrawal itself may take longer than that.
Right,
if you're not treating it.
So my question to the entire panel: do you ever see a day where the 3 to 5 day detox is followed by either mandatory Vivitrol or a treatment center? Because the 3 to 5 day detox is killing people, in my estimation. I mean, that's the way I feel. I mean,
can I ask one question?
Sure.
When you say 3 to 5 day detox, what is that treatment that you're referring to? Is this just
hospital
cold turkey? Watch them withdrawal?
Yes. The police officer will find someone on the street, or someone will overdose in a house. They go to detox in a hospital somewhere, in a hospital setting. They detox, let's say 3 to 5 days or 7 days, and they're out. Hopefully you have some place that they can land, that they can be treated. Heroin is a lot stronger, obviously, than nicotine or caffeine.
Yeah.
So
I mean, theoretically, naltrexone actually shouldn't be given to anybody who's used opiates within 10 days. So the idea of letting somebody withdraw and then giving them naltrexone, you may, even if it's been 3 to 5 days, you may, if they're even coming out of it, you may actually induce worsening withdrawal by giving them a Vivitrol shot. If you're asking my personal opinion on this, and I'm going to try to do the best I can to kind of put my spin on this, too often Suboxone, because it's classified as an opiate, and it is an opiate, it works on the opiate receptor.
correct.
Too often we see it as, the most common word I hear is a crutch, right? People believe this is trading one addiction for the other. That actually can't be further from the truth. people that use Suboxone, what it does generally is it makes them feel more normal before they use drugs before. Since you can't get high on it, and since it doesn't induce the euphoria associated with opiate use, it's not addictive, right? Now, again, I've talked to people who would argue with me all day whether or not it's addictive or not. Addiction, like I said, is seeking the drug despite negative consequences. The negative consequences for Suboxone are probably along the lines of constipation, and that's about it.
Right.
It doesn't lead to death. So allowing, and to address a program that would allow somebody to detox in a way where you just simply watch them suffer, I'm not sure who does that. I hope that there are a few programs that do that if they do that. But those people should absolutely be given Suboxone to treat that withdrawal. And I would equate this to the idea of, somebody had touched on this, and this is part of the education that I give to providers and to other people who like the science behind this, is I mentioned neonatal abstinence syndrome and the rates of neonatal abstinence syndrome. And this is the child born to a mother who's using opiates who comes out and the child withdraws. And the rates are high, right? And everybody who talks about this, you start to feel the lump in your throat because you think about these babies. We treat neonatal abstinence syndrome with opiates. So if people think it's okay to let people withdraw and watch them withdraw, would we allow that for a baby? Would we just sit there and watch a baby withdraw and hope that, if it needs to be intubated, we would intubate it? I mean, it's not a judgment or a question, but we have good tools now to treat withdrawal, and we should absolutely be doing it at every turn. Naltrexone's ability to help with withdrawal is none. It would induce withdrawal. But its ability to help with relapse is still being studied. The original studies say that long-term relapse rates are the same with naltrexone as they are with Suboxone. They're absolutely the same, whether you give it as a pill or a shot. It's about a 70% that they will stay sober with those medications. The problem, of course, is that most people, when they're having problems with opioids, they're withdrawing. They're not coming to me, they haven't used in 2 months and they're just looking for a drug because they're having cravings. That's pretty rare. And those people I do try on naltrexone. I do, right? Because naltrexone, even as safe as Suboxone is, naltrexone is even safer. So it's not necessarily that it doesn't have a place. But the place more likely in the future for where we're treating this is people on Suboxone who, after treatment for however many years or how long it takes, who want to come off Suboxone. And that's when I say want, I mean the patient decides whether or not they're going to come off. If they do, I would encourage all of them, once they're off Suboxone, to go on naltrexone. Okay, I would. And to be honest, I've been doing this 3.5 years. I have 0 patients who have ever done that. 0. Nobody has ever come off Suboxone and gone on naltrexone in my program. But when you look at addiction as the disease and how long it's treated for, it is the same as everything else. The studies are saying that people need to be on Suboxone their entire lives.
Correct. Thank you. I appreciate that.
Sure.
That last comment was great.
Yeah. And one more to add here.
Yeah, and so over at Southeast Missouri Behavioral Health, we do have a 3 to 5 day detox program. And so I think it's important to understand what the purpose of the different levels of treatment are. A 3 to 5 day detox isn't intended to necessarily treat all of the underlying things that may exist for that individual who is using. It's really, its only purpose is safe monitoring through that initial period of what they consider to be the dangerous period. So with opioid use, you won't die from the withdrawal of opioid use. You're gonna feel like death, but you're not gonna actually die from that. Now, for alcohol use and benzodiazepine use, the withdrawal from that can kill you. And so the most dangerous time period, for example, with somebody who's using alcohol, for example, is the point right before and at they get to not having any more alcohol in their system. So the purpose of detoxification is to safely monitor that individual during that most dangerous time, and that's really all.
And again,
I would say too, I'm sorry, if I misconstrued that, because if it's more of a watch them for a certain number of days, not everybody who comes off opiates withdraws, right? So when we're talking about withdrawal and not to correct, but people actually do die from opiate withdrawal. Opiate and alcohol are the two big withdrawals that actually do kill people. But when they do withdrawal, if they're in severe withdrawal, there's no way that people should be holding them in a clinic or any facility that doesn't have the ability to treat withdrawal. Those people should be treated. If they're in severe withdrawal, if they're sitting there vomiting their guts up, looking like death, diarrhea and stomach pain out of the world, those people need to be treated. Now,
Absolutely.
if people are just coming and going, look, I last used heroin 12 hours ago. I'm not sure if I'm going to have withdrawal, and we're going to monitor, and they may get a little agitated. They may feel a little cramping. That's not what I'm talking about. I'm not saying every person needs to be instantly put on Suboxone. What I'm saying, though, is that the levels of withdrawal need to be evaluated, and I'm sure anybody that's doing a detox program, they would recognize the ones that need to be sent to the hospital, because
Right,
that stuff is scary.
my biggest concern is after that last day when they have detoxed completely and are let out the door, that they are given something to go home with. Thank you.
The something they could go home to with as well is Suboxone, though. That's I think we need more use of that, honestly, more providers.
And I think it's important to know too, when Dr. Kirkley's talking about the elimination of the waiver to be able to prescribe Suboxone. Now, for emergency room physicians, they can prescribe a limited day supply, a 3-day supply of Suboxone without being waiver trained.
And unfortunately, as we see in almost all communities, there are not nearly enough Suboxone prescribers. So after that 3 days, they're withdrawing again, and it's hard. It's very difficult right now.
First of all, I'm a recovering addict. I got 14 months clean, and I would like to see more help with Suboxone whenever you go to detox, because sometimes we just get clonidine or something like that, and that if a person ain't getting what they need to get treated in detox, they're more liable to leave. Like I had a friend that come out from the city and go to SEMO, which I'm not down in SEMO at all, because I love SEMO. They saved my life. But he went to detox, and he couldn't get nothing for like no Suboxone or anything. They was just giving him clonidine for the 3 to 5 days. So I would like to see, can we work on that?
I don't want to speak for SEMO, but I'm sure they would too. Yeah. That's the finding the resources. That's the limiting part of that.
And I just wanted to add to, like, speaking for SEMO, that is something that we are looking at trying to actively pursue, is that what can we do for everybody? The only problem is that, everybody's their own individual. And, as far as I'm not going to speak, on behalf of whatever physician that was, but when they evaluated that individual, they must have thought there was some reason why they did not want to go that route, because we definitely don't put any kind of limitations on any of the physicians that we use. So the fact that he did get a medication tells me that he did see a physician, and there must have been some other factor involved in that decision making. But we want to offer the most effective form of treatment and the most evidence-based practices for treating addiction, which is always a combination of medication and therapy.
Hi, I'm not sure if anyone here will be able to answer my question. I'm actually a social worker with 20 years experience in the mental health and substance use field, and I am the mother of a heroin addict. Been suffering with her addiction for 2 years, and just about 1 week ago, I know that she has a warrant, and she called me from a local drug dealer's house claiming that she was being held captive in the restroom. So I called the police on my daughter. Who does that? Hi. I told them that she has a warrant and I would like for her to be arrested. I met the police at a secure area, and in the meantime, as we were going to the house, she phoned again and said that she had fled, escaped, and was hiding in the bathroom of a local restaurant. So I followed the officers there. We located her in the bathroom, And it was very evident that she had a syringe sticking out of her jeans. Well, they couldn't frisk her because there was 2 male officers there, so they took her to the station and I followed them. And they came out with a syringe full of what appeared to be brown tar heroin. They simply released her straight onto the street with a warrant. I'm pretty sure I'd still be in jail if that were me. And, they offered no help whatsoever. So now I still wonder every day, where's my daughter? Is she alive? Because since that time, due to lack of help from the authorities, I have no idea where she is or if she's alive. Thank you. Speechless, huh? Thank you.
Well, on behalf of law enforcement, that does sound kind of strange. I don't know, there's a big difference between the federal government and then local law enforcement. And I don't know if maybe they were confused about the Good Samaritan law or something, but obviously there's something that's probably, not really correct there. So I would think we all would be just about as, confused as you are. So I'm sorry I don't have a good answer, but that would be something that, and maybe they, what a lot of people are doing now when they get arrested, she didn't even bond out, it sounds like. So she wasn't even, So that's strange. Normally what'll happen is they'll go ahead and book the individual and then, release them pending charges. And then it's up for, the prosecutor to actually file charges. So I'm kind of confused as well. So sorry I don't have a cut and dried answer.
We do. We just, I think yesterday we found a senator, a state senator that's going to pre-file the bill in December for us. So hopefully this is our 4th year with a syringe access bill. So we'll see what happens. Last year we had the whole mess with the governor because it kind of shut down all the legislation right there at the end. And quite honestly, it's the state that we live in. Most of the overdoses and accidental overdoses and the high rates of HIV and things like that are in St. Louis metropolitan area, Kansas City, Springfield area. And so the legislature is represented by people from rural areas. I'll give you an example. A couple of years ago, we were at the hearing on the, we were having a hearing in front of committee for the syringe access bill. And the chairperson, we got up there and we presented all this data. We presented the Scott County, Indiana information. We presented, how much their return on investment, hoping that they'd hear that on what's being spent on Hep C through Medicaid for the state by the state of Missouri. Presented all this data, and the chairperson's response was Pope Pius, I don't know, the 13th or something, was against it. And how are you going to beat a pope, right? But that's what we get. That's what we're up against. Either deeply religious, rural representation, or just the conservative. Lock them up and throw away the key. It's just now that the state. You asked about decriminalization of certain things or alternative sentencing. It's just now that the state's looking at it. And why are they looking at it? Because of budget concerns, right? We can't build enough prisons. They ran out of money for the prisons. So now they're willing to start looking at restructuring the sentencing laws, getting rid of some mandatory minimums for nonviolent offenses and things like that. Listen, Europe does it the opposite that we do. they do treatment up front, and then if you don't successfully complete that, then they do punitive on the backside. Whereas we say, well, we can successfully treat 60% of the population with about $10,000 with treatment services. But no. See, we want to spend $44,000 to lock them up this year and then send them back out on the street suffering from the same substance use disorder. And then I'll just finish with this and I'll shut up. We were talking about the barriers. The FDA has deemed that buprenorphine is safer than Adderall, safer than Adderall, right? By the schedule of drug that it is, right? Any doctor can prescribe you 500 Percocets tonight. But in order for a doctor to prescribe buprenorphine, which is safer than Adderall that we give to 9, 10, 11-year-olds, this doctor has to go through 8 additional hours of training. Then he's only allowed 30 patients his first year. Like, we have all these barriers to people getting well, right? Here's what France did. France got rid of all barriers. They said, you don't even have to have an OUD diagnosis. Anybody can come in, any physician, anybody can prescribe it. You can give it to them right out of the office. Here's the buprenorphine. Within 3 years, their overdose death rates dropped by 79%. So if you guys want to do something for me, vote. Contact your state legislators. Contact your state senators. That's how we're going to get things changed. We're not a lobbyist. We're not lobbyists. We're 2 guys that rode up to Jefferson City in my old Ford Explorer, and we knocked on doors until we found somebody that had been affected by this. When we found a state, his name was Stephen Lynch. When Stephen Lynch, his best friend's son had died from an accidental overdose. When we found him, we started getting traction with some of this legislation. It's not because we wrote amazing bills. They weren't supported, but we found somebody that was emotionally attached to it and not just financially, right? We need just regular people to stand up and say, every 3rd household in this country has been affected by addiction. We need people to start saying something about how we spend our dollars. If you can do anything for me, vote this year. Contact your state legislator. Tell them that we need some help. We don't have Medicaid expansion in this state. That's why everybody goes over there. That's why Illinois has a lower overdose death rate than we do. And our drug supply is poisoned here. The DEA agent talked about that. You can't even find heroin in St. Louis. I am almost like, when I see the bus in the paper of heroin, I'm almost like, let that through. They weren't dying like they are with the fentanyl. And the drug dealers aren't exactly working in a sterile environment when they're weighing up their dope. So that's why the people that are buying meth are accidentally overdosing because it's got fentanyl in it. The people that are buying cocaine, the weekend warriors, are accidentally overdosing. Right? That's what's going on in our area. Sorry to be a bad news guy.
Talk to her about the syringe program. So down here, we are definitely trying for a syringe program. We have talked to the Department of Health and Senior Services, and they said that we could do harm reduction. But if needles are exchanged in any way, they are to come out of like an outsourced pocket. So we are definitely trying to get something here. It's been a year now that we have just pushed and pushed and pushed. But like he was saying, you have to go and talk to your legislators because they're the ones that are going to push this bill through and make it where we can have something like this to help people.
If they hear from 5 constituents in each district, that's when they listen to us. 5. If just 5 of you from this district emailed tomorrow and said, I support syringe access programs because it saves lives, then when I go to Jefferson City at the first of the year, that one's actually gonna listen to me. That's what we need. It doesn't take much.
Amanda, I don't know if you said this earlier, but I wanted to mention on syringe access. Places that have syringe access programs actually have a higher rate of people in treatment and recovery as well. So it's coupled with the program of getting people into treatment and recovery resources as well. Now I'll go back to being the mic lady. Okay.
Hi, my name is Sherry Hampton, and I'm a program director for a newly formed program for diversion. Like you were just talking about, the feds have decided to start spending some money. We applied for it, and we got it, and we're trying to provide intensive services to substance abuse users who have lost their children, helping to expedite getting those children back. Unfortunately, there's so many people that have this need, and we have such limited amount of services. However, I have two questions for you. We do offer the MAT for that reason. In our program, we like to support that. But we are finding that the people that are in our program cannot sustain that cost once we can't help them pay for that. Do you see that ever becoming something that will be more affordable or that insurances will cover? And then my second part to that question, I'll just go ahead and ask it because you probably can answer it at that time too, is I know that medical marijuana is becoming something that is past here now. It's fixing to start happening. How do you think that that is going to affect the opioid issue?
I'm assuming that was for me. Okay. So Suboxone is generic. Once people realize how much money can be made by selling Suboxone through pharmacies, you'll see competition that will drive the price down. And so, yes, I do believe it will be affordable. I don't believe it'll be affordable like $4 prescription affordable, but I would say you will probably see cost ranges somewhere in the $30 to $60 a month at a standard 16 milligram dose within the next few years, would be my guess. I've not bought any stock in any company that makes Suboxone. But the second one about medical marijuana is, I think, very, very difficult. The studies around medical marijuana are not high-quality studies. So the problem with studying medical marijuana, and I just, I know there's a very political opinion about medical marijuana and marijuana use in general. In general, as a doctor, I don't care about marijuana. It doesn't restrict access in my program. If people are positive, they're positive, and I don't care. But when people ask me if it's useful, because they read the story about some kid who had 500 seizures a day, who now only has 15 seizures a day because they're taking marijuana and they tried every other drug, I still say, do you think 15 seizures a day is a good thing? But it's almost impossible to study marijuana. Because when we study drugs, what happens is we isolate the chemical, we measure it, and we put it into a milligram or a unit dosing. So we know how much we're giving people. That's not what's happening with marijuana. Marijuana is typically taken, and if it's smoked, there's no way to measure it all, number one. Secondly, if it's put into an edible, it's usually given as like a percentage of THC versus CBD, but it doesn't tell you how much of each of those is actually in there. And so it's hard to standardize whether or not it's useful on any level because you don't know how much you're giving people. You could be completely underdosing, trying to figure out if it helps reduce pain, overdosing if you're trying to figure out if it helps with sleep, or anything in between for what other indication people think it's useful for. Personally, I think that it probably does have some uses, but when you see studies coming out now that say that medical marijuana does not actually decrease the amount of opiates people use for pain, they have me very concerned about this idea that it's some wonder drug that people think it is. It is probably neither the devil nor the angel people think it is. It probably works really well for a very small handful of people, and it works really poorly for a very small handful of people. And the other 95%, it's like drinking a glass of wine in your house. So I think that if you want to know more about medical marijuana, what they're going to have to do is they're going to have to figure out how to standardize it in a milligram so you can test it. Double-blind and placebo-controlled trials. It's a way to know, but we can't really do that now. Nor do I see anybody really working to figure this out, which makes me concerned that there's too much money in legalization for anybody to actually know the answer, right? We like to study drugs after there's no more money to be made. because then we find out a lot of drugs don't do stuff, you know. But when there's money to be made, nobody really wants to know the answer. We just want to make money until then. So, sorry, I think that is more of an opinion, but. It's okay. You might have anything else to add about medical marijuana?
We are like really close to. I'll take one more question, but they're trying to kick us out of here. So,
No pressure for the last question, by the way.
I know we've talked a lot about the adults and addiction, but I'd kind of like to know more what we're doing with kids. I mean, I feel like a lot of school districts aren't even doing the DARE program anymore, and I feel like the whole thing needs to be revamped. I lost my oldest daughter back in August. She fought with heroin addiction for 2 years. She was 4 days after her 21st birthday, and she was clean for 9 months before that. And I look at this child that taught herself 8 instruments, was going to go into the military, and I think these kids need a program that shows them that it can trick anybody, or ways to take pain medications when they have a knee injury in high school, football. They need to be educated in those ways, not just the, here's how you say no, here's a clever way to walk away from your friends who are trying to trick you into taking drugs. You know, I feel like the whole thing needs revamped. And our children who are going to grow up into the adults who are going into these treatment programs could be educated in a more aggressive way, in a more real way, and a more, they need to realize it can be them. I guess I feel like kids already think they're invincible. That's just part of it. But they don't, I don't know what the answer is. And I know I was ignorant to it until it touched our lives. We've never dealt with it before. And so when I saw what it did to this child that I would have never, ever thought would have been able to have been tricked by this, I realized how much more we need to be doing in our schools and how much that needs to be changed. And I just wondered what you guys thought on that.
So I do prevention and I'm in 20 counties, but we recently have been doing a CQI project with Johns Hopkins University, and we actually started this year a program in Poplar Bluff called Smart Moves, Smart Choices, and we go in and we discuss misuse of prescription drugs, but we have revamped it a little bit to go over all different kinds of things. When I first went in to talk to these kids, they were teaching me things that I had never known. And so now we go in and we've shown a film called Written Off. I don't know if anyone's seen it. If you can, it is a story about a young man's journey with heroin. And it really speaks volumes to these kids. And then we go into the curriculum. So we teach them what is misuse of prescription drugs. A lot of these kids think, oh, if my friend gives me a pill, it's not bad. And so we're trying to change that view for these kids. We're seeing more kids, especially in Butler County. We've had several kids overdose and die with heroin. And so we want to get in there in the high schools and junior highs and middle schools and talk to these kids and make it relevant. A lot of parents might not like that, but we've noticed that these kids are really learning a lot when we do our pre-test and post-tests, and they're opening up to us. So we can talk to them about Narcan and tell them they have options. And then afterwards, you have these kids texting you on Facebook or messaging you and saying, how can I get trained? So I think once we have this program, now we can flourish it everywhere if possible, if school districts want it. That's the thing. The school has to want it. We can give them all the tools to implement it, but it would have to be the school district's decision to take it and run. I know that our school district has done it. This will be the second year, and it's went fantastic, and the kids have learned. And no, they do think they're invincible, and some of them don't think that they're going to learn anything, but at least getting in there and just showing them is a progress in my book with these kids because they think they're invincible. So we are out there trying, and we are trying to move that education throughout Southeast Missouri. So we're trying for sure.
That's one of the primary things I do is go into schools and talk to kids through all ages. Like I mentioned earlier, you know, my son going up to the people in Walmart parking lot, I never told him anything about cigarettes. He got that at school, like in second grade, and developed that perception. But it is all about getting asked by the school. There are some schools that they just want to have this, we don't have a problem. And I always try to say, well, it doesn't, you might not have a problem now, but we're trying to give these kids something in their skill set when they're 20 years old, when they have that accident or when they're exposed to that type of opioid. So you as parents, just like Robert was saying, as far as voting, you have to be the squeaky wheel. Call the school and ask, hey, I heard you guys aren't doing DARE anymore. Why not? Well, okay, well, hey, DEA will come to your school and put on programs for free. There's a lot of other organizations out there who'd be happy to come into the schools, but the schools just have to ask for it. 8th grade health is the best. I'm pretty sure in Missouri, 8th graders are required by law to have a week of drug class. I always tell every school, I will come out and teach the class. And sometimes I'll be out there for 2 or 3 days in a row teaching health the whole entire time. And today we're talking about this drug. Tomorrow we'll talk about a different drug. So like you have to ask for it. Beat up the schools. You know, sometimes the administration is always changing, and you have to be that squeaky wheel to make them, you know, reach out to us.
And one of the other things to do, like that was mentioned earlier, is talk to your legislators. I mean, the laws are changing all the time. There's a hand in the audience because we have one of our state legislators. Now he's made himself known. Yeah, Dale Wright, one of our state representatives here with us. We're happy to have him. But talk to them about it because the laws are changing. And you know, they've recently made suicide prevention a mandatory part of school policy and having prevention programs in the schools. And for the St. Francis County, the resource is prevention consultants. So I would reach out to them and ask them too what they're doing in the schools, and they'll be able to provide you with a lot of information. Additionally, the youth treatment provider is Preferred Family Health Care, who treats for substance use in the ages of under 17 years old.
I just want to say our schools, I don't know if there's anybody from the school, but all of our schools are looking at this. It's something that we've been working with them on at the health department, and they've been involved with our opioid consortium. So they're looking at it, and they're thinking about it, and they are wanting to make changes to the curriculums. They're also thinking a lot about vaping right now because that's a really big topic, which is a whole other thing. But just know that they are thinking about it, and they are looking to make improvements. And I know that some of them are already on the steps to instituting evidence-based programs for that. That being said, we're always thinking about prevention. I think at the health department, we care about prevention deeply. And that's something that we're always asked about. But it should be known that some of those things are not as easy to nail down. When we talked with the CDC, when they came to St. Francis County, which is a really good thing and also a really bad thing if the CDC comes to your county. We asked about prevention and kids and those types of things. And there's a lot of things that are going to be happening around adverse childhood events that put people at risk later in life to develop a lot of different things, but especially substance abuse disorders. So that's a harder thing to nail down, is how to address adverse childhood events. And I know that that's something that they're going to be working on, and at some point maybe something that we're working on as well. But that's something to note as well. It's not as easy as a thing, and there is no silver bullet for these things, or we'd be doing it.